Everybody high. Blood pressure is typically measured in the sitting position, but this approach can miss patients whose hypertension is only revealed when lying down. Supine hypertension, an under-recognized condition, has been shown in recent studies to be associated with increased risk of coronary heart disease, heart failure, stroke, cardiovascular death, and all-cause mortality, sometimes paralleling or exceeding the risk of conventional hypertension. Despite its significance, routine protocols for detecting and managing supine hypertension are still lacking in most clinical practices. Who should have supine blood pressure measured? Supine blood pressure assessment is especially valuable in patients with borderline or controlled seated blood pressure but persistent target organ damage, e.g. left ventricular hypertrophy, microalbuminuria, carotid plaque. Older adults, particularly those with autonomic dysfunction or orthostatic symptoms, patients with suspected or known nocturnal hypertension or abnormal nocturnal blood pressure patterns, non-dipping or reverse dipping on ambulatory monitoring, patients with resistant hypertension where supine blood pressure may uncover additional hypertensive burden, heart failure patients or those at high risk cardiovascular despite normal office blood pressure. Several pathophysiological processes contribute to supine hypertension. Central volume shift, lying down increases venous return, raising cardiac preload and systemic blood pressure, particularly in patients with impaired vascular compliance. Autonomic imbalance in older or autonomically impaired patients. Blunted sympathetic withdrawal leads to persistent vasoconstriction in the supine position. Endothelial dysfunction, failure of vascular compliance amplifies pressure changes. Nighttime blood pressure correlation, supine hypertension closely mirrors nocturnal hypertension, a strong independent risk factor for adverse cardiovascular events. How to measure supine blood pressure correctly? Have the patient rest supine for at least 5 minutes before measurement. Use a validated upper arm cuff positioned at heart level. Take at least 2 readings 1 minute apart and record the average. Compare supine with seated blood pressure to identify discrepancies. What to do if supine hypertension is found? There are no unique guidelines for treatment, but suggested approaches include confirm findings with repeated clinical measurements of ambulatory blood pressure monitoring, incorporate overall cardiovascular risk and target organ damage into management decisions, optimize antihypertensive therapy if indicated for general hypertension, consider evening medication dosing in selected patients with nocturnal or supine hypertension, use non-pharmacological strategies for autonomic failure such as elevated the head of the bed. Refer resistant or complex cases to a hypertension specialist. For many patients, especially those with autonomic failure, the risk and benefit of pharmacological therapy require individualized assessment. Key takeaways. Supine hypertension is common, easy to detect, and strongly predictive of adverse cardiovascular outcomes. Routine screening is not indicated for all, but targeted assessment in high-risk individuals can identify hidden risk, leading to more personalized and effective care. As evidence accumulates, guideline recommendations may involve to formally incorporate supine blood pressure measurements, especially for older adults and those with complicated hypertension. Thanks for likes and sharing.